includes the pons and the medulla. What's going on down there? Respiration rate, exactly. Okay. What is the reticular activating system? What do you guys remember from that? Reticular. I don't think it's even.
It does similar functions as the cerebellum.
Reticular activating system. Okay. The reticular activating system can keep somebody awake, kind of in a vegetative state, but they're not really responsive to the environment around them. Remember the cerebrum. Say, Mr. Jones, how are you? Oh, I'm doing fine. Has your daughter come in today? No, not yet. But if Mr. Jones has some kind of edema, some kind of damage up here, he may still open his eyes, but he wouldn't respond. Sometimes this can be kind of distressing for the family because they're going to see Mr. Jones open his eyes, but he won't respond. They're like, oh, he's fine, he's going to be okay. No, probably not. So just know that the reticular activating system is in the pons and medulla kind of area. It's a little strip of tissue. And it only controls wakefulness, not thinking, not executive function, because that's what's up here in the cerebrum. Does that make sense? Okay. So if there's dysfunction infratentorially, there will be a decline in consciousness. We talked about kinesthetics and balance, and the oculomotor and respiratory response. If there's herniation through that tentorial plate, where those first 4 cranial nerves are kind of hanging out, there'll be clinical manifestations from dysfunction there. Okay. So when we assess level of consciousness, there can be a number of levels that we can assess. Pre-hospital folks and in the ER, you're going to look at, especially when people come in, if there's been a trauma or they come in very acutely ill. AVPU. Who's taking first aid? Sometimes talk about this in first aid. Do you know what AVPU stands for? It's levels of responsiveness.
I think it's like alertness to verbal and oh, I got this. I should know this. Alertness to verbal, is it like
To person?
You're thinking alert and oriented times 3 or 4. Alert and oriented times 3 or 4. This is you're alert. You wake up to verbal only.
Oh yeah, pain and oh come on.
Urination.
Oh, or is it unresponsive or something? Okay, thank you.
Pain.
So like you do like sternal rub for one of those like unresponsive people. You do
Beautiful.
Sternal rub and all that.
That is exactly right. Good for you.
Thank you.
Yay, yay. So when you're coming upon Mr. Jones and you say, hey, Mr. Jones, how you doing? And he says, I'm doing just fine. He is alert. Mr. Jones, how you do? He's lying there with his eyes closed. Mr. Jones, wake up. Huh? What? Something like that. Kind of like you in the morning before class. Alert to pain. You have to get a little bit more assertive here. Mr. Jones, wake up for me, and he doesn't. So then there's a number of things you can do. What are some things that you can do to, you can do a sternal rub. Pinch them.
I don't know, like
Okay, pinching them actually right here is very effective in the trapezius. This is classic though, in the trapezius, when you really want to wake somebody up. Pinch yourself in the trapezius, hard. Ow. Well, you want to actually elicit pain because they got their eyes closed right now. Yeah, so you can pinch them generally here. Fingernail is also pretty good. But you see if they respond to pain. If they don't, then they're considered unresponsive, the U. So those are the classic levels of responsiveness that you want to assess. Okay. AVPU. Alert and oriented times 3 or 4 is person. This is getting more into looking at executive function. You know, how alert are they? Person, place, time, event, what brought them in, what's going on with the situation is. And please, if, I can't tell how many times this has happened. Mr. Jones, what date is it today? And then, you know, I have to do as a nurse. Oh my God, what date is it today? Don't expect more from the patient than you can't provide. So, you know, is it Monday, Tuesday, Wednesday kind of thing. So, you know, that can be time as well. So we're looking at different levels of that cerebral activity. And even minor little changes, please notice it and don't poo-pah it. I say that for a reason, based on experience observing novice folks myself, because you doubt, oh, was there really that much of a change? I don't know. So document carefully, and even the smallest little change can be significant, especially when you talk about patients who are admitted to the hospital for a head injury of some kind. So please notice the small changes. They may be significant. So you ask them these questions. My PowerPoint isn't moving there, but it is here, which is very weird. So we know that, where again is the breathing center? The pons. So if we're having issues with the breathing center, what do you think may physiologically be happening in the body? Lack of oxygen, lack of perfusion.
Intracranial pressure that's like resisting over the plate.
Yeah.
The plate is like causing a resistance because it's just below it, so it's like pressing down.
That's exactly right. There may be herniation going on. There may be a bleed that's actually around the brainstem area where the respiratory center is taking place. Remember one time, this one I was in Tillamook. I was walking down the hall, I was giving somebody a tour, I don't remember why, but a daughter of a patient runs out in the hallway, grabs my hand and says, "There's something wrong with my mother!" Told my guest. I go into the room, and the mother is breathing like this. Her head is down, she's sitting up. What do you think that means? She doesn't, she's not getting enough oxygen. What else? What makes you say it's a blocked airway?
Well, it's because she's constricting down here, so like, I don't know, we don't know her airway and like how it is, like her anatomy, so.
That sound is probably her tongue blocking her airway a little bit.
Yeah.
What kinds of questions do you think you want to ask yourself?
How long has she been doing this? Open airway maybe?
Yeah, the first thing I did is open the airway. Yeah. What is she admitted for? Well, she was admitted for TIAs, transient ischemic attacks. So what do you think might have just happened?
She had an attack, briefly.
Probably more, what is a TIA?
Mini stroke.
A mini stroke. So what do you think actually happened right now?
She had a seizure and that.
Well, probably big fat old, big stroke. Yeah. And very likelihood in her brainstem, because you can have strokes in your brainstem, that will impact the respiratory center. Now, I'm only surmising, but based on my understanding of anatomy physiology and my collection of data, that's what that's what we want to teach you guys. You're collecting data to help you come up with a conclusion. I think that she probably had a big stroke. So I did indeed lay her down and put her head back, and then she stopped snoring, but then she stopped breathing because that respirations they were just agonal anyway.
What's that mean?
Agonal is, thank you for asking that. Agonal is like they don't count. They're like last ditch. They're like, and then you don't breathe for like, 30 seconds.
Like your last
They don't count.
effort.
It's a last effort kind of thing. Yeah. And my hands were hovering over her chest because her pulse was getting slower. then the social worker came and people were grabbing my wrist a lot that day. She's a DNR. I don't see anything in the chart. Here's the daughter, she's a DNR. Okay, the code team had arrived. But we put together the data of what we're noticing. And that respiratory sign was this, is apneustic. Apneustic respiratory pattern means that there's dysfunction infratentorially. Okay.
How do you spell that?
Apneustic is, it's down here, A-P, ap,
Oh, I can kind of see that.
I don't know. I can say it.
Oh, sweet, it's going right.
A-P-N-E-U-S-I-S. A-P.
N-E-U-S-I-S.
N-E-U-S-I-S. That means very, very slow, last ditch. This doesn't count. You're certainly not raising your SpO2 with this kind of breathing. Okay. Infratentorial, probably direct pressure on those respiratory centers.
It's a little
I gotta go faster. Another type of breathing dysfunction pattern can be what's illustrated in B. It's hyperventilation. It's central neurogenic hyperventilation. B, central neurogenic hyperventilation. The breathing is going over 25. Okay, I'm gonna take off my mask here. Okay, not good. There is dysfunction within that respiratory center. Again, infratentorially. And these are nice illustrations of just what that breathing pattern looked like. If there is dysfunction supratentorially, okay, in the cerebrum, we may see something like Cheyne-Stokes. Cheyne-Stokes is a respiratory pattern that shows there's a dysfunction with the brain understanding the levels of CO2 and oxygen in the body. So we have a pattern of apnea, and then rapid breathing, and then apnea, and rapid breathing, and apnea, and rapid breathing. And these can be caused by hematoma, stroke, trauma, or tumor. It's just, for some reason, there may be increasing intracranial pressure supratentorially in the cerebrum. If things keep getting worse and the pressure keeps increasing, it will push down through the tentorial plate area to the infratentorial region, and will move into hyperventilation and perhaps lack of ventilation, just apnea. How do you guys feel about those breathing patterns? Pun intended. Yes, ma'am.
So initial trauma, or yeah, I guess initial trauma would cause A, and then when the pressure got worse, it would cause B?
Possibly, but remember my little illustration of when the lady grabbed my arm?
Yeah.
That right away was already apneustic, because probably the bleed was down there right away anyway.
So you can jump straight to B, basically, is what you're saying. There doesn't have to be A first.
That's exactly right. It depends on where the situation, where the pathology is taking place.
Okay. I have another question.
Yeah.
So if the breathing centers in the pons, which is already infratentorial, why do you get disruptive breathing with the supra if it doesn't put pressure on the tentorial plate yet?
If you get dysfunction in the supratentorial area, that means there may be an epidural hematoma, which we'll talk about in a little bit. There may be something going on up here that then it takes a little while for that pressure to rise and herniate down to the brain stem. So that's what can cause the different levels of breathing dysfunction. But the big thing to remember, you guys, is noticing that there is dysfunction. Okay? Notice the abnormality. Describe the abnormality to your healthcare partner, which is your physician. sometimes you don't even need to label it. Just say, you know, Dr. Smith, I'm calling you today because I'm concerned about Mr. Jones. I walked into the room and I noticed that his breathing rate is 8. When I checked him last time, it was 12. What I notice now also is that his vital signs are this, his level of consciousness is this, and I'm very concerned. I need you here now. So putting labels on things is wonderful if you can do that. The big thing, I just want you guys to know, the big thing is noticing when there's dysfunction. Does that make sense?
Yes.
And how is that? Does that make sense about just the levels of breathing?
I think so.
Okay. Remember Cheyne-Stokes is that alteration in apnea and hyperventilation, okay? This can occur if there's dysfunction in the cerebrum, when there's dysfunction in the pons, the brainstem, just the whole brainstem area, which includes the pons and the medulla. It may cause these 2 different patterns of hyperventilation or apnea. Okay. So respiratory pattern is super important to be part of that assessment. So far we've talked about 2 assessments. Level of consciousness, we talk about ABPU, how responsive are they, executive function, and now we've talked about our second assessment to do, and that's breathing pattern. Now the next type of assessment we want to do is looking at motor response. What kind of change, the big thing is noticing change from a previous assessment. I can't stress enough how important it is to notice trends. Physicians love, that's why they love to see dots connected together a lot. Temperature is going up and blood pressure is going down, connected with little lines. So we want to look at motor response. How do they feel? Are they having any seizure activity? Are they posturing, which is the next slide. We'll talk about posturing. When somebody, we talk about the words contralateral and ipsilateral. When you have somebody that has had a stroke, perhaps in the right hemisphere of their cerebrum, because of the way nerves connect, okay, there's a normal crossover of nerve fibers at the tentorial plate in the brainstem area to the other side of the body. So if you have a right-sided stroke, you'll have left-sided motor dysfunction. If you have a left-sided stroke, you'll have right-sided motor dysfunction. Eye changes are often on the same side as the stroke because that nerve crossover doesn't take place until the brainstem area. Okay. Who's had yes ma'am?
Oh, no, you finish and then I'll ask.
Okay, who's had like a relative that's had a stroke? Is that what you noticed as well?
I'm not sure if it's stroke, you know, the exact thing, how like the bleed was on the left side and it's affecting the right side.
That's exactly right. It's really, really rare. And in fact, physiologically it can't happen. It's, you know, because of the way the anatomy physiology is, it's going to be on the contralateral side.
What if it's in the middle of the person? That was actually my question, is like what if the bleed is in the center? How is that going to affect it? Because I've had people in the past who have both right side and left sided issues. And is that caused by something in the middle?
That's a very, very good question. There may have been multiple bleeds.
Okay.
There may have been multiple strokes. What are strokes? What is oftentimes the etiology or the hypertension can be something that causes it. Clots. Clots or bleeds. So if you have a clot, clots can come from the lower extremities. It can come from someplace in the heart. Oftentimes those clots will shower. What do I mean by showering? Spread. Yeah, there can be multiple clots and multiple blood vessels in the brain, so that's where you can have both sides affected.
Okay, I was curious because I've seen that. It's really interesting.
Yeah, and it can happen. It can happen. I mean, you can throw multiple clots for whatever reason to different parts of the brain, and where that clot is will determine the clinical manifestations that you see, whether it's visual, olfactory, you know.
I believe he had 3. Actually, no, that I'm right. Yeah.
He had 3? Yeah, it's possible. How do you all feel about that? Good, 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 good. Okay, posturing. What do you all know about decorticate and decerebrate posturing? Have you ever heard the words before? Okay. With significant central nervous system pathology or hypoxia, that hypoxia can cause damage to the nerve fibers in certain ways that cause something called posturing. Okay. The decorticate posturing, I always remember decorticate posturing because their hands would go to the core. Decorticate posturing is caused by damage. I don't want to get them confused. Decorticate posturing is from damage to the spinal cord, and decerebrate is from the cerebellum. I just want to verify.
So decorticate.
Upper brain stem, yeah, upper brain stem. This one's worse. Okay. And this is hypoxia or bleed or damage more in the cortical spinal pathways. Okay. An illustration of when this might happen is, here's a little bit of a quick story. So I'm the nurse who has to man the CT scanner for a little while, and we get a call from the ER where they say a young man is coming over who's having the worst headache of his life. What can that mean?
Pressure.
Pressure. He's having the worst headache of his entire life, and oftentimes that's a very ominous sign. He ended up bleeding. He had an aneurysm, a brain aneurysm that ruptured. So that's what we were thinking. So we get him into the CT scanner, and the radiology.
It's under your paper on the table.
It is. I'll just use the blue one. There we go. Thank you. We get him into the CT scanner, and his little brain and his skull. And we get to a certain area of the slices that the CT scanner does, and we see it pretty much blacked out. What does that mean if it's blacked out?
Tissue death.
Tissue, yeah, he's bleeding. Hypoxia from a clot doesn't show anything on CT scan, but if something is totally blacked out, it means that he's bleeding. So he's in the CT scanner and he starts doing this. Look at the picture, and what are my hands doing? Yeah, it's kind of half and half, but I remember he was doing half and half. And we saw that, we got him out, and he was coding. So we did the cardiac, we did CPR and all that kind of stuff. But was anything going to save him? No. Unfortunately not. What is an aneurysm? It's a blood vessel that burst. So that's what happened. Any of us in this room could have a little weak aneurysm that could blow.
My cousin was 18 and he had one when he was just doing military training. But he lived, but he's...
Thank goodness. Thank goodness.
Yeah, but he can't like communicate well anymore, and he's in a wheelchair, and he does have his wrists are always curled stretch.
Yeah, gives you the range of motion. I mean, it's really sad. So you do everything that you can. Hopefully you can happenstance, maybe he's having a CT for some other reason that's totally unconnected, and they see a little pooching of a vessel and they say, oh, you have an aneurysm, we're gonna fix that. And yeah, we'll fix the other thing later on, but we're gonna fix this now. Because aneurysms can blow. This can happen from, stroke, motor vehicle accident. It's caused by increasing intracranial pressure that's damaging the cerebrum or the spinal cord. And so we watch for this thing called posturing. and that's motor response. That's the third assessment that we do, is motor response. Questions about decorticate and decerebrate? It's scary as all get out to see it, let me tell you that right now. Yes, ma'am?
You differentiated at the very beginning when you were talking, which part of the brain is affected by which part. Can you go over
Okay,
that one more time?
this is in the cerebrum, the upper part of the nervous system. This is decorticate? No, this is
No.
decerebrate,
Decerebrate.
and this is decorticate. Hands go to the core.
And that's because.
And that's in the
It's because
more
of your
damage in the
spinal
brainstem.
cord.
Spinal cord, yeah.
Yeah.
Versus cerebrum.
Right.
But you said cerebrum is, wait, cerebrum's top one, you said?
Yes,
Yeah.
cerebrum is up here. This is this one.
Okay.
Yeah,
No, the cerebrum is down.
cerebrate or corticate.
Corticate and decerebrate.
Yeah.
Yes.
Did you say one was worse? I think you
Yes,
pointed
this
to
one is worse.
Okay.
This one is worse. This is upper brain area. Okay?
Thank you.
Yep. Okay, we talked a little bit, but this is our fourth assessment. We're gonna look at pupils. We're gonna look at those cranial nerve activity. The first one, again, is olfactory. But 2, 3, and 4, we're gonna look at vision acuity. Sort of. See if they can still, you see the same as you did before. But the big thing is pupillary response and oculomotor. If their eyeballs move, that's trochlear. So the third cranial nerve is oculomotor, and that's specifically pupillary response. So you can put your pen light in, have them look at your eye or open up their eye and take a look. And what you should see is not only reaction on one side of the eye, but the other side the other eye as well. Okay? So if there's unequal pupils, there's hypoxia on this side of the brain. There may be hypoxia, as was brought out. There may have been multiple strokes or multiple bleeds. That can cause pupillary dilation on both sides. Or systemic hypoxia can cause pupillary dilation. It's called meiosis. I want to spell it right.
So you're saying an unequal pupils is just pure hypoxia of the brain, that's it?
There's pressure on that third cranial nerve that's causing tissue hypoxia.
Okay.
This condition is called, I want to spell it right, mydriasis. Mydriasis. There's an A in there. Not that's going to be on a test or anything, but you know, there's lots of big words in medicine. Mydriasis is when there's pupillary dilation of one or both pupils. Okay. That's caused by tissue damage, tissue hypoxia. This can also be caused by opioid overdose. So looking at pupils is a good assessment. It is one of the 4 that we talked about for central nervous system assessments. Okay? Questions on that? This is the last slide we're going to talk about today before we do a little exercise. So I think our timing is pretty good. So thank you for that.
Yeah, we're on 11:53.
Yes. Excellent. Okay. So this is a very, very busy slide. We'll spend a few minutes on this. When somebody's admitted, I'm going to give you a little scenario. A sweet little old lady gets admitted because she slipped on a rug. This is a real story. She slipped on a rug. It's like 8 o'clock at night, and she hit her head. You know, she wanted to get up and go pee. She's on a stupid diuretic, so you know, you gotta get up all the time at night. And she slipped and she hit her head on something, and she had a brief loss of consciousness. Then she called, you know, paramedics because it scared the crap out of her. They came and they picked her up. And so now we have physician's orders. She's admitted to the hospital for observation. And we've got orders for Q2 hour neurochecks. Q2 hour neurological checks. Okay, those neurological checks are just what we talked about. Checking level of consciousness, checking respiratory rate, so we'll just do all the vital signs. So checking level of consciousness, vital signs. We're also looking at pain, but that's not on here, and looking at pupils. Those are the assessments that we just talked about, okay? This is it's a very busy slide. It's a really good slide because it illustrates as her damage, maybe she's got a little bit of a bleed in her head. As that bleed expands, it causes pressure on her brain. That pressure on her brain will manifest in these vital signs, changes in mental status. We talked about that. Awake and alert, is she confused? You know, what's going on? So you're going to do that. You're also going to look at her pupils. We talked about that. We want to check to see if her third cranial nerve is impacted. Is there herniation going on? We got to assess that. What is her breathing pattern? We talked about that too. We want to see if there's enough swelling to cause pressure on her brain stem. So we're going to assess that. We're going to check her blood pressure. We didn't talk about that real significantly, but we'll talk about the changes that happen. We'll talk about her pulse, and then just temperature variation. These are neuro checks, and this is what you must do for all patients who have a concern about their neurological status. Okay. So it turned out our lady died because checks weren't done frequently enough. But you know, she's admitted to the hospital, and you know, the first hour you do a neuro check, and you say, you know, hi Mrs. C's. Her name is Martha. That's not her real name. I'm just giving her a name. Martha, how are you doing? Tell me about why you're here. And she tells you a story, and she's awake and alert, and she's, oh, honey, I'm so clumsy. I slipped. I was getting up to go pee because I'm on that stupid pee pill. So she's very animated. You know, she tells you the story. You look at her pupils, say, Miss Martha, I gotta look at your pupils, and they're brisk, and they respond, and they're good. And you get her vital signs, and everything's pretty much good to go. Say, okay, Martha, I'm gonna let you rest for a little bit, because we know that one of the things that we have to do for taking care of somebody who is on this neurostatus concern is decrease environmental stimuli. We don't want the brain to work too much. You know, we don't want loud music and TV on, because shoot, if you guys are on the computer, a lot of it makes your eyes and your brain hurt too, doesn't it? Oh, yeah. So we want to decrease environmental stimuli, so we turn out the lights and we say, Martha, I'm going to be back in a couple hours, and I'm just going to check on you. I don't want to disturb you too much, but I do have to ask you a few questions and check your vital signs. Is that okay? Oh, honey, of course, that's just fine. So 2 hours later, you do an assessment. She's bleeding in her head. So now what you notice is that she doesn't wake up quite as quickly. You have to, you know, kind of maybe touch her a little bit. Miss Jones or Miss Martha, wake up, look, oh, who's there? I don't see you very well. You're looking a little blurry. Oh no. Now I look blurry. I wasn't blurry before. I wonder if her optic nerve is being impaired somehow. But she's able to answer questions. She knows she answers more slowly, but there is a difference. You notice there is a difference. Her pupils still look okay. So you look at her pupils. And her breathing is still okay, so thank goodness. You know, she's breathing about 16. And her blood pressure is okay. And her heart rate's okay. And her temperature is okay. But you did notice something that is a little bit suspicious. At this point is when you want to notify the physician. She is admitted for a neurological concern after all. And she didn't respond to you like she did. And I know it's midnight, and I know she's an old lady, but you know what? I really don't care, Dr. Smith, if I'm waking you up at midnight. I'm concerned about my patient. You can be mad at me if you want. I really don't care. I say it this way because this is why our patient died in real life. The nurse did not check on her because she wanted to be, he or she, it was a gal, because she wanted to be nice, because she didn't want to wake her up because it is midnight and you know, she's supposed to be sleeping because it's the middle of the night. No, that's wrong. So be the mean nurse and just wake them up. Because a couple hours later, because we didn't tell the physician, a couple hours later, she is harder to wake up. I'm looking at her pupils and they are sluggish. They are sluggish, they do not respond like they used to. So picture this bleed that is now kind of herniating and putting more pressure on the second and third cranial nerve. Oh, honey, you look really blurry. And her pupils are not responding like they should. And now at this point, her breathing may still be normal, but maybe there's a little bit more difficulty breathing going on. The big thing that you want to notice, there's a change in blood pressure. Okay, you want to write this down because when there is increasing intracranial pressure, the pulse pressure, what's the pulse pressure again? What is that?
Are you the CPP?
We're talking about the pulse pressure.
What's that noise?
I
It's a
hear
machine
it's
outside.
a machine outside.
Oh yeah, I think it's the
Oh.
trash guy backing up.
Oh, okay.
Is it
Or
like the one
Amazon.
plus, when you like feel it, it's like pulsating, because it's strong perfusion?
Pulse pressure is actually the difference between two numbers.
Cranial pressure.
Yes.
Oh, there you go.
Pulse pressure is a difference between the systolic and diastolic number. Okay. Systolic usually goes up, diastolic may go down a little bit, but there's an increased pulse pressure when you see increasing intracranial pressure. Please remember that. It's classic. In addition, because there is some herniation going on, there will be some bradycardia. If there's herniation going on through that tentorial plate, it'll put pressure on the brain stem where we have different receptors that regulate heart rate. Okay, vagus nerve and all that kind of stuff, cranial nerve number 10. It'll cause some bradycardia. The central chemoreceptors, remember, also in the medulla, and they regulate respiratory rates. So we'll see some kind of change. It's usually a bradypnea or a slower respiratory rate. That's been my experience that I've noticed. But there'll be change in respiratory rate. And the very small print down here, if we're in stage 3, notice that what we need to do is surgical or medical intervention is needed here. So either they need to, well, somebody needs to call the physician. We need to evacuate the hematoma, or we need to provide some IV fluid intervention to cause some fluid shift, to get fluid out of the brain. What kind of bed position do you think we can put somebody in who's filling up with fluid up here? Set them up. Put the head of the bed up. It's probably one of the best things that you can do. Because if she's lying down flat, fluid is going to kind of sequester in the head. So put the head of the bed up, keep their neck straight. Yeah.
Is there like a specific level of pressure before they do like a, oh my gosh, I'm forgetting
A
the name.
bolt, a little
Yes.
bolt thing. It has to be clinically significant. Sometimes if they're taking out, if they're going to surgery and they're going to remove a clot, they'll go back to neuro ICU. And because there's been a surgery that's happened, oh my gosh, well, there's a surgery, there's going to be inflammation. It kind of goes along with the deal. So they'll go back to the surgical ICU and they'll have a bolt. They'll have a little pressure transducer that reads, there's a little sensor that goes to the transducer. I have a picture of it, but I can't show it to you.
This is terrible, but the little thing that you stick in a turkey.
Yeah, it actually kind of is, except it doesn't measure temperature. It measures pressure in there.
Yeah.
What is normal intracranial pressure supposed to be?
0 to 15.
Good, 0 to 15, that's exactly right. Okay. Yeah, so they go to surgery and they come back with that. So we have to somehow cause fluid shifts to decrease that intracranial pressure. What's normal? We already said normal intracranial pressure. What's normal mean arterial pressure supposed to be?
70 to 110.
Good. Because that is involved in the math equation for figuring out cerebral perfusion pressure. We have to make sure that we have enough oxygenated blood getting to the brain as well. If one is too high or one is too low, it's going to cause maybe cerebral hypoxia or hypertension, and it'll cause the bleed to expand a little bit more. Stage number 4 is when we can have significant pupillary effect. Blood pressure just kind of starts getting worse. Respirations are involved. Patient starts getting bradycardic even more, and there's usually bad outcome if it comes to stage 4 because there's been so much brain tissue involvement that usually it's a bad outcome. So I know the chart looks really busy, but that's what we're looking at. Different stages of herniation, different stages of involvement, and the assessments that we've been talking about today, the assessments that you need to do. And remember, those assessments are looking at level of consciousness, which is the quickest first thing that you can notice, okay? Even the smallest change in level of consciousness can be significant depending on the patient's situation. Pupillary changes are actually usually last. That shows, that manifests. As we look here, it definitely is. It's in stages 3 or 4. And look at the complete set of vital signs to include the respiratory pattern, okay? And you're also looking at sensory input. Are they starting to posture or something like that? So those are the 4 assessments. Tell me what questions you have. What do you think about all that?
So with blood pressure, we would expect a high systolic and a low diastolic in stages 3 and 4?
Yes, a widening pulse pressure, and generally what happens is the systolic goes up. That being said though, remember that, I'm going to throw a little caveat into this, okay? Remember that cerebral perfusion pressure. What is cerebral perfusion pressure? What does it stand for? What does it mean again?
The amount of oxygen getting to the brain tissue.
Right, the amount of blood and oxygen that's getting to the brain tissue, okay? ICP, remember that was, what is normal cerebral perfusion pressure again? 70 to 100. Okay. 65 to 110. Not that's mean arterial pressure.
So they're asking that.
Yeah. It's 70 to 100 or 70 to 90.
Yeah. 70 to 90. Okay. Let's say, you can work out a number of different math problems. Let's say that a patient had a stroke. Okay. They had an embolotic stroke because of hypertension. Their blood pressure is usually a little bit high, and their mean arterial pressure is like 130. Okay. I've seen blood pressures of 220 over 110. So MAP sometimes that's not good. Yeah. So MAP sometimes can be pretty high. Minus. So they had a stroke, so we expect some swelling. So let's say their intracranial pressure is 25. We're only guesstimating because there's no bolt in there or anything like that. What kind of cerebral perfusion pressure do we need? Or what kind of cerebral perfusion pressure will that be?
105.
Wouldn't that be 105? I thought the cerebral perfusion pressure was the ICP minus, the MAP minus the ICP.
Right, she doesn't know.
Yeah, I've got it backwards.
Yeah.
MAP minus ICP equals cerebral perfusion pressure.
Oh, she's.
Yeah.
Right, it's like, if we did the math like you have it written, it'd be negative 105.
Yeah.
Okay, well, do it so it's a positive number. It turns out to be, is that going to be high enough? Yeah, that's probably okay. It's a little bit high. What if we wanted to get that blood pressure down lower because we're concerned about a MAP of 130? Let's say because 120 over 80 is a map of about 72, something like that. So, okay, let's say that we don't know the difference and we want to get the map down to 72 and their ICP is 25. What's that? What's the cerebral perfusion? Huh? 47?
I'll check that.
Is that good enough?
It looks good enough, but
It's not. We want to talk about something called permissive hypertension. Permissive hypertension, sometimes when somebody's experiencing increased intracranial pressure, the physician is actually going to be okay with the patient being a little bit hypertensive because we need to have that number be higher so they get perfused in their head. And you can discuss, because Lord knows I have the discussion with the physician saying, man, I'm really worried about this gal's blood pressure. It's like, 180 over 90. Don't we want the blood pressure to be down a little bit? I mean, she just had a stroke and I'm really concerned that she may stroke again. And the physician, I guarantee, will say, if it goes any higher, let me know. But right now we're okay with it because we want to have adequate cerebral perfusion pressure. So we're going with some permissive hypertension right now. Yeah.
So in the word permissive hypertension, you're referring to like allowing the hypertension
Yeah.
to exist
Yes.
for a set period of time and then you'll fix it?
Yes.
Okay.
That's exactly right. As the edema goes down in the head and as the patient gets better, we don't want that blood pressure to stay high. We'll medicate them or whatever we need to do to get the blood pressure to go down a little bit more. But for the time being, because we know there's more pressure up here, we need to have the blood pressure be a little bit higher so we can maintain adequate perfusion in the head. And that's called permissive. We're permitting the hypertension. How do you guys feel about that? Does it make sense? Okay. So, we only have 10 minutes left of class. We're gonna do a little exercise related to Cushing's triad. Now, we talked about all the components of Cushing's triad. And it involves a high systolic pressure, a low pulse, and low respiratory rate. So I want you guys to kind of pair up and work through this situation.
I plan to record that. I'm typing it in now to reference that for cheat sheet. When I had blood clots and I had intracranial pressure, I was gagging because the room smelled like Christmas trees so strongly and there was not a tree in sight. But I was like, it smells like Christmas trees. I need to get out of here. And she was like, it's not going to go away in a different room. No, all this is powdered. Only bring me all the time. It smelled like Christmas trees. This is the day that I my texture and oh yeah, my heart looks like right. Just make sure like sit back down. You can't handle that. Yeah. I know our guy like tries to go down.
Heart rate and
I definitely have a thought. I was like, but how is that related to
yeah.
just like of the
Oh, like these? That's increased adrenaline. Oh, Oh, yeah.
Yeah, respiratory rate is quite a lot.
And maps today. Just one more? Okay, let's do respiratory.
I have actually
It might be a little bit off, so
respiratory rate is going down.
if there's any extras on the end.
So, transit shows that
Or the end over here, any extras or anything like that?
And systolic pressure is back to actually decreased slightly instead of increasing. So it doesn't look like pushing our child. Yeah, it doesn't look like that.
Anybody need another one of,
Yeah.
Of course you can. That's very, very costly. Yes. Because of moving all yeah, yeah. Just looking at diagrams.
So if you see that your brain
It is like very aware. This is the way it probably is. Hopefully the big one down there is not. And that one. I know it.
Do you have anything else to lecture or?
That's going to be it.
Stopping it?
Yeah, we can stop it.